Okay, everybody, can you hear me? Can anybody hear me? Okay, we start in 30 minutes.
Hello, Dr. Surveyor. Let me change the background. There we go. Hello, Dr. Surveyor. Oh, sure. Are you there?
Hi, John.
How you been?
I'm good. How are you?
Good. I see you're sitting in the front row.
Yes, I'm sitting in the front row. How are you? All well?
Yeah, very good. Yeah, we had a nice pediatric neurosurgery.
Yeah, I was there yesterday. Yeah.
Oh, good. You were there. Great. Great. That was
Yeah,
that was a good one.
Well, you told me that I'm a second time now doing residency.
Oh, no, okay. That's right. That's right. This is your delayed residency.
Delayed residency. Yeah. So,
I tell you, I wish I was a med student now.
yeah.
Wow. Wow. It would be so. I think it would be a little more fun for me.
Yeah. It's
I
a
like
fun to learn. See,
Yeah.
learning is a process. You can't stop learning.
Yeah. Well, if you can make it fun, it's even better.
Yeah. And we learn from everyone. We learn from everyone.
Well, one good thing about medicine, you just learn to surround yourself with
Yeah.
something, and you just absorb it. You know,
Yeah.
I know during residency, I learned a lot of things I didn't realize I learned them because they were just around me all the time,
Yeah.
just like anybody in
Yes.
training in the world. You know, you're around it all day, you absorb it.
Yes.
Some of it, anyways.
It's good fun.
Yeah. So, okay. Hi, Dr. Surveyor.
Hello, how are you?
Good. I got the Kahoot. It's all ready.
Super. I've just finished my surgery just now. I'm just rushed.
Oh, okay. What kind of case you have?
I had a brainstem tumor in a child of 3 years.
Oh, a child.
Yeah,
Oh, okay. So you do pediatric neurosurgery as well as regular.
I do oncology for the adults and pediatric. So
Oh,
brain
okay.
tumors, basically.
Okay. Luckman, I'm trying to get you in. I don't know what's going on. I can't get you in. Luckman Hadi, can you speak, Luckman? I see you're trying to get in. I just, for some reason, but you should be able to speak. I see your hand up. We got 7 minutes, Dr. Spare.
Super.
Hello, Saeed. Yeah, Mossab is here.
Hello, Dr. John. How are you?
Good. How you been?
Yeah, thank you very much.
Yeah, welcome.
Welcome. Thank you.
Mossab, you did you get in okay, Mossab?
Yes, John?
Yeah, I was just talking to Mossab, but I guess he can't hear me. He's still helping you out with these, right?
Yes, he is.
Okay. Yeah, Eleanor can't make it today. She's writing her thesis,
Sure.
but I encourage her to network with your daughter.
Yes.
It,
She's
it,
more
it
than
always
welcome.
helps to know a neurosurgeon, you know, when you're in train, you know, you're a student.
Absolutely.
I'm sure she has a lot of questions. Is Mossab there with you, or
Yes, he is still, yes.
oh, can he get in at all? I'm trying to get him in. I see. He
Well,
can.
he's here with me in the room. Do you want him to get in?
No, you don't have to. No, I just was wondering because he's in the panel, but No, there's no problem. There's nothing really to talk about. How's the COVID situation there in Jordan?
Much less, much under control.
It's the same?
Much less, and much under
Oh,
control.
much less. Oh, that's
Yeah.
great. That's great. Is there still a lot of restrictions on?
Well, they have been eased off generally,
Eased a
but
little
they're
bit?
still on, yes. You have to wear a mask, you don't have to accumulate with other people, and so on.
Hello, Dr. Ibrahim Sbeh. How are you?
Hello, nice to see you.
Hello. Said
Hi.
Ben Ali from Marrakesh, Morocco.
Yeah, of course, I know you. Thank you.
Welcome, welcome.
Welcome, Doctor. How are you, Dr. John?
Very good. Nice to have you here.
Thank you.
Okay, 1 minute.
Yeah.
Hello, Professor Ibrahim.
What was that? I didn't understand.
Yeah, this is Dr. Harshad Parikh.
Oh, okay.
How many webinars Dr. Ibrahim has done so far?
Dr. Sabea?
Dr. Ibrahim.
I don't. Dr. Eben, does anybody understand that Dr. Eben? I don't quite understand. But well, hang around. You ready to start, Dr. Sabea?
Yeah, I'm ready.
Okay, let me start the hold on, the YouTube. Okay. 10, 9, 8, 7, 6. Hold on, Dr. Sabea. Can you stop sharing your screen? Because it takes
Sure.
yeah, just until I make your
Sure.
introduction, okay?
Sure.
And then after that.
Out.
Okay. Let me 10, 9, 8, 7, 6, 5, 4, 3. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have another Jordan Neurosurgery Grand Rounds with Ibrahim Sabea. Has been doing these for a long time, most lately on Zoom. And we also have a Kahoot quiz at the end of the broadcast, which we will grade and give prizes. So anyways, welcome, Dr. Sabea. It's all yours.
Thank you, John, and hello, everybody. We'll start sharing the screen.
Yeah,
Okay.
perfect, perfect.
Good evening or good morning, wherever you are. My name is Ibrahim Sbeh. I'm from Jordan, and this is the place I work in Amman. It's the Farah Medical Campus. And this is the black iris, the symbol of Jordan, which I usually put during my lectures. And today we're going to discuss a very unique topic, which is the cervical spinal dumbbell schwannomas or neurofibromas. It's very unique because dumbbell tumors are unique. So we'll discuss that from the clinical, radiological, operative, and pathological points of view, as usual. So we're speaking about spinal dumbbell tumors. Some people may not understand what dumbbell is, especially if we have some medical students in the audience. Dumbbell, like dumbbells that we use for weightlifting and so on, it's an hourglass-shaped tumors, part of it within the spinal canal, part of it outside. So it looks like an hourglass or a dumbbell. So there are 3 compartments: spinal compartments within the spinal canal, the canal, foraminal canal, and the paraspinal part. People think of dumbbell tumors as schwannomas. It's not. Only 50% are due to schwannomas and neuromas, while 50% others are other tumors, And we tend to forget that. We tend to think of Dumbbell tumors as just Schwannomas. 50% of Dumbbell tumors are not Schwannomas. So as we come up meningiomas, I had cases of meningiomas presenting like Dumbbell tumors, metastasis, ganglioneuroma, chondrosarcoma, giant cell tumor of the bone, osteoma, osteosarcoma, owing, hemangioendothelioma, leiomyosarcoma, osteoblastoma, and osteodysteoma. So many tumors present like Dumbbells simply because they are in the vicinity of the body and the foramen. Some examples of the last case, actually, I have a Dumbbell tumor. This is chondrosarcoma in the cervical region. And one must not forget that sometimes the tumors are, you think they are only inside the spinal canal, but you are not aware that they have this silent, what we call silent connection through the foramen. And you don't see that on MRI, especially low Tesla MRIs. So to speak about Schwannomas and the Neurofibromas, are they the same? The answer is no. Theodor Schwann, a German pathologist, 1810-1882, he coined, or the name of Schwann cells were named after him. Schwann cells after Theodor Schwann. And if you look at both Schwannomas and Neurofibromas are equal among males and females, and this is the age group that they come across 25 to 50 years. We come to another pathologist, Friedrich von Recklinghausen, and the name of NF1 von Recklinghausen disease is named after this German pathologist, von Recklinghausen disease. So we have three types of neurofibromatosis, but the three of them are due to genetic disorders. NF1, neurofibromatosis type 1, NF2, and schwannomatosis. NF1, after which they named neurofibromatosis type 1, von Recklinghausen disease, it's a genetic disorder at chromosome 17, while NF2 is at chromosome 22. What's the difference? You can get here Schwannomas and you get Schwannomas here. In NF2, mostly it is vestibular Schwannomas with other tumors. In schwannomatosis, it is also at the chromosome 22, but it is non-vestibular Schwannomas. So NF1, NF2, and schwannomatosis. Come back to the Schwannomas and the Neurofibromas. You have the dorsal root and ventral root. These tumors arise mostly from the dorsal root. Only 5% arise from the motor root. So mostly Schwannomas and Neurofibromas arise from the sensory root. Other names that you may come across in literature of Schwannomas, they were called neuronomas and neurolimomas. These almost are obsolete names now. We stick to Schwannomas, but you may come across the neuronomas and the neurolimomas. They are all names for the Schwannomas. So Schwannomas, they arise from Schwann cells. They are well capsulated. They are extrinsic to the nerve fibers. You can separate them from the nerve. And when they are multiple, as I said, we call them NF2. So here you are. These are nerve fibers here within this nerve. And this is the Schwannomas from Schwann cells. It pushes everything to the periphery, and you can actually separate it. So this is the false capsule, which is from the neural tissue around, and this is a true capsule. But you can separate these from the nerve. So you have pseudocapsule, you have true capsule, and as I said, in the pseudocapsule you may find some fascicles, and this is Schwannoma, the true capsule within. So this is a Schwannoma where you can separate it off the nerve. You can see fascicles, and one of them gives you the tumor from Schwann cells, so it will push everything aside. On the other hand, the neurofibromas, they don't arise from Schwann cells. They arise from fibroblasts. That's why they are called the neurofibromas. Also, they have perineural cells, and sometimes some Schwann cells. They are not capsulated, in contrast to the Schwannomas. They cannot be separated from the nerve, in contrast to the Schwannomas, which can be separated. And neurofibromas, when they are multiple, we call them neurofibromatosis type 1, in contrast to the Schwannomas NF2. So this is a neurofibroma. You cannot separate it from other nerves or other fascicles. And when you have a plexiform form of this neurofibroma, especially in the face, NF1. So where are they located, these Schwannomas and the neurofibromas? In the cervical region or in others? 75% are within the dura, but extramedullary, which is expected. 15% are totally extradural, and only 15% are dumbbell. And there is this rare type where you'll find Schwannoma intramedullary. Some people would say, how come? How would you get intramedullary Schwannoma? Here you are. This is the axons, and these axons are embedded inside the spinal cord. So when the tumor arises, it will be intramedullary. I looked into literature, only 46 cases in literature were reported of intramedullary Schwannomas. And I'm fortunate to have one of those cases. I will tell you about it. The explanation of intramedullary Schwannomas, that there are axons displaced within the cord, like in this case, or axons accompanying arteries inside the cord, or you have ectopic Schwann cells. So there is an explanation of why we have intramedullary Schwannomas. As I said, I was lucky to have this patient who came to me from Libya, 34-year-old patient with this intramedullary tumor. It's totally intramedullary. I did not think that this is a Schwannoma at all, but in surgery it was intramedullary, as you can see, and we removed it completely without any neurosurgical or neurological deficits. And this is the postoperative MRI. And this is the patient himself. So, dumbbell Schwannomas, they can be lumbar, then thoracic and cervical in this order. So they are more lumbar, followed by thoracic, followed by cervical. Or they can be at the craniocervical junction. Let me give you some examples. Again, I choose the examples from my patients. If you don't see the name here, so most likely I get the example from literature. But once you see this, the name, the age, the gender, so these are my patients. This is lumbar Schwannoma. Another lumbar Schwannoma, here you are. It could be thoracic. It could be in the cervical region. Again, this is a patient of mine. Cervical Schwannoma. Another cervical Schwannoma. They come in all sorts of shapes and sizes. Or they can come across the craniocervical junction. And this is one patient of mine, 58-year-old female patient. The tumors or neoplasm of Schwann cells are 4 types. The neurofibroma, which we described, which is mostly from fibroblasts, but they are also arising from Schwann cells. Schwannoma, typically arising from Schwann cells. And we have the malignant peripheral nerve sheath tumors as a 3rd type of these neoplasms. What about histopathology? And I hope our colleagues, the histopathologists, are around. I'll just give a brief introduction, and we'll ask them to speak to us about this. So histopathology, if you get a neurofibroma, Schwannoma, and sent to your histopathologist, he will report spindle cells arranged around blood vessels in pseudo-rosette pattern. So this is blood vessel, and the cells, the spindle cells, are distributed around it. Another example here of blood vessel, and the cells are distributed around it in pseudo-rosette pattern. Again, blood vessel, and the cells are arranged around it. So this is one of the main features of Schwannomas. And the other main feature is to see alternating areas of Antony A and Antony B. Again, for junior staff, medical students who are in the audience, Antony A are these spindle cells which are condensed Antony B, they are scarce. So an area condensed cells and the area with the scarce cells. Antony A, Antony B are sort of alternating. And this is after Nils Antony, a Swedish pathologist. And again, the Antony A, Antony B zones are named after him. Another name that you came across is Jose Verrocchi, and these are Verrocchi bodies that he discovered, which are always associated with Schwannomas, with the Schwann cells. There's even a stamp in his name. He is Uruguayan Italian pathologist. The cells are S100 positive, and this is typical of Schwannomas. EMA, epithelial membrane antigen negative, again, because I'm not dealing with epithelial tumors. GFAP negative, because I'm not dealing with glial tumors. P53 is also negative. These are the immunostaining that one should do, and that we always do in our department in Jordan, in Amman. Progesterone negative. Synaptopsin is negative. Factor 13 is negative. Pancytokeratin is negative. So these immunostaining are essential to diagnose the tumor. And also, when you do the Ki-67 index, which shows you the multiplicity of the tumor, usually it's around 1. Sometimes, in this case, one case of mine, it was rather aggressive, and the Ki-67 was 10%. So that is more towards malignancy. So let's come to the dumbbell spinal schwannomas, which is our topic for tonight. How frequent, how often do we see these cases? I looked into literature, the old and the new. This 1963 paper by Love and Dodge, published in the spinal cord tumors. They had 1,000 cases of spinal cord tumors, and they had 60 dumbbell tumors. So that goes with the frequency that I have alluded to at the beginning. Another paper by Genai, Neurosurgery 2005. He had 149 patients, 42 were dumbbell. Again, going with the general frequency in literature. Third paper by Schwannoma, Surgical Strategy for Cervical Dumbbell Tumors, Spine 2003, 42 cases, 38 were Schwannomas, 38 of dumbbell tumors. So 42 cases dumbbell tumors, 38 were Schwannomas. The previous paper, 149 dumbbell tumors, 42 were dumbbell, 42 were Schwannomas. Nismetin Pamer, my friend from Turkey, reported 82 cases of spinal tumors. He had 9 were dumbbell, and in thoracic he had none, and 31 were dumbbell. So this is 82. So the frequency of these cases is very shown in literature. What about the classification? I found the classification is the most awkward. I looked at it carefully, and sometimes it is confusing. So you have multiple classifications, but there is a lack of consensus regarding the optimal classification system. Why are we bothering ourselves about the classification system? Because you need to have some regular classification so people would define what approach they have for this time or that time. But let me show you the diversification of the classification in literature. Very diversified. There is Eden classification, which is taken as golden standard, standing till now since 1941. Nato and Zong, 2000, Sedar from India, Sedar and Ramurthy in 2001, Asazuma and Toyama in 2004, Jinai and Koyama in 2005. So many classifications. Let me just take you through part of it, and you will get confused about which is the best one to follow. Let's take the Eden classification, which is the old one, 1941. Type 1 is intra and extradural. So most of the tumor is within the dura, small part of the extradural. This is rare, 9%. Type 2, we have intra, foraminal, and outside. This is common, 33%. Type 3 is the same, but it is larger. The foraminal part, the paravertebral part is larger. And this is the commonest. So this is the commonest type, 53%. Type 3, where you have the paravertebral part is larger than the others. And type 4, which is rare, it is totally extradural. There is nothing within the spinal canal. It's only in the foramen and outside. So back to this classification, this is the commonest type. Another classification, Yuntao and Zong, 2000. They put this illustration showing you the spinal cord and the roots and the dura, the arachnoid coverings, and the pia mater coverings. So they call this type 1. Type 2A, without involvement of the root. Type 2B, with involvement of the root. 3A, large, involving the root and coming outside. Type 3B, further extension outside. Type 4, sort of really dumbbell, but in 3 shapes. So again, if you go back to this is confusing. You cannot put your cases according to this classification, and it is difficult to remember. Sardar classification, Sardar and Ramamurthy from India, back in 2001. Type 1, type 2, type 3, type 4, where you can see that's some invasion of the vertebral body, in addition to the foraminal part and the paravertebral part, and it goes through the lamina also. And type 5, which is solely within the body of the vertebra. Again, this is difficult one to apply. Type 6. Genai, 2005, put also as a classification. Group 1, strictly within the dura. Group 2, intradural and extradural, but still you are in the canal. You did not go out. Group 3, extradural within the canal. It is not intradural. Group 4, extradural within the canal and out. Group 5, intradural, canal, foramen, and outside. Again, the difference between these 5 groups is difficult to ascertain, and it is difficult to put your cases according to this classification. Nakamura, 2013, also put his classification, type 1. We are still within the spinal canal, part of it within the dura, part of it outside the dura. Type 2A, extradural, within the canal, and part of it within the foramen. 2B, you are outside the foramen, you are going into the paravertebral space. 2C, you are in the foramen, paravertebral larger than the one before. Type 3A, intradural, foraminal, and just sitting outside. Type 3B, extending outside. Type 4, going into the vertebra. Type 5, going through the lamina, translaminar. And type 6, it is called multidirectional, going everywhere, through the body, the lamina, and the foramen. Again, look at this classification once more. It is difficult to apply. I like the simple classification, and I thereby advocate Nismetin Pamer, my friend from Turkey, a beautiful paper, 2017, simple thing to apply. He looked at the tumors and he said, it is not enough to say whether it is within the canal or outside. Also, we have to look at the tumor volume and how many levels they are occupying. So a schwannoma on one level, C3-4, is different from one which is taking 3 levels. So the tumor volume, tumor size, the multiple levels of the spine involved is very important. And to me, this is very important advantage of this classification. In addition to the tumor location, whether it is within the canal or outside. So 2 classification, one regarding the tumor, volume, size, and extension, how many levels, 2 centimeter, 2 to 4, more than 4 centimeters, which means that you have multiple spinal levels, and the location, whether they are intradural, foraminal, or extradural, like this. Type 1, type 2, are still within the canal, type 3, just getting out of the canal, and type 4, completely outside the foramen, and the combination of these types. I must mention this paper by Atul Gur, my friend from India, 2018, in addition to other papers that Atul published on this topic, the surgical approaches for C2 neuronomas. And again, he's using the neuronoma terminology, which is now being changed to schwannomas. And he would say that intraspinal tumor is interdural. So this is the nerve root, which is okay. This nerve root is involved, so the tumor goes like this. So it is interdural, which is very interesting theory. How do these schwannomas present? Obviously, one can tell the presentation, localized pain, radicular pain. You may have sensory deficit, you may have motor weakness, you may have synthetic disturbances. What about management? Basically, we are talking about surgery. Radiosurgery and radiotherapy are palliative and given for those cases where you cannot operate. Before we go into the surgery itself, let's just remind ourselves of the anatomy, and here we're discussing cervical schwannomas and neuronomas. So let's look at the anatomy of that region. C1 is atypical cervical vertebra. This is from the top, from below, from the anterior part, and from the posterior part. One has to remember the anatomy there, and you have to remember exactly what is the vertebral foramen in relation to C1 and C2. C2, again, from above, from below, from anterior, and from lateral, with the Dumbbell process. And the C1, C2 junction or articulation, allowing certain movements of the head, and so on. So here you are, of typical cervical vertebrae. They are both CF class and axis on top of each other. And this is looking from above, where you can see the C1, the superior articular facet, the Dumbbell process, and the canal. The rest of the vertebrae, C1 and C2, are atypical. They are special, unique vertebrae, and the rest are typical, except maybe for C7 because it is not bifid. All the typical ones are bifid. C7 is not bifid because you are in transition to the thoracic vertebrae. So this is the uncinate process, and this is the foramen for the vertebral artery, and so on. And this is typical cervical vertebra, as you see it from above, from below, from anterior, and from behind. Again, one has to have this visualization of the vertebrae to be able to operate on that area. The other thing that one has to remember and be careful about is the vertebral artery. Which part you are dealing with, V1, V2, V3, V1 from the subclavian to transverse foramen of C7 or C6. Mostly it is C6, 10% are in C7. V2 from C6 till C2, and V3 from C2 as you go around C1 and then into the inside the dura, and this is V4. So this anatomy must be absolutely mastered before thinking of operating on any dumbbell tumor, schwannoma or otherwise. So various views of the vertebral artery from posterior to anterior to lateral You have to have this X-ray image in your mind whenever you are operating there. Vertebral artery, how do you visualize this? If you're looking at the vertebra from anterior, how do you visualize vertebral artery? This is V3 coming from C2, going anterior, lateral, upwards, and then going through foramen of C1 at the back of atlanto-occipital joint and inside the dura. Again, as you see it from the back, this is C2, and you go, this is V3, going anterior, lateral, and then up, and then through the transverse foramen of C1, back of the atlanto-occipital joint inside the dura. And one has to remember what Al-Mufti has mentioned in one of his papers about the multiple venous channels around the vertebral artery as it goes between C2 and C1. Horrible veins there. And if you are operating there, you have to prepare yourself for a lot of bleeding and a lot of problems there. And he called this vertebral cavernous sinus because he resembling this to the carotid artery being surrounded by the cavernous sinus. So also the vertebral artery is surrounded by this mesh and plexus of veins. So this is the relationship of the vertebral artery to the schwannomas. So this is a very intimate relationship, and one has to be absolutely careful. Because when the tumor goes through the foramen, the vertebral artery will be pushed, will be narrowed, will be displaced. And again here, this is posterior, this is anterior. As the vertebral artery goes through the transverse foramen, the nerve roots are anterior to it. So vertebral artery is posterior to the nerve roots. What about surgical approaches for these tumors? Some rules govern these approaches. If you go for total resection, maybe you'll have morbidity. If you go for subtotal resection, surely you'll have recurrence. So the pendulum swings between total resection and its advantages and disadvantages, and total resection with these disadvantages. And there's always the question of spinal stability at these junctional areas. So the surgical approaches for dumbbell schwannomas, posterior, anterior, anterolateral, or combined. But I have to mention this, that most of the cases are done via posterior approach. You can really reach to any tumor there, to any size you like, but sometimes you are forced to use the anterior or anterolateral or combined. So if you use the posterior approach, the old laminectomy approach, the hemilaminectomy approach, and the semi-hemilaminectomy approach, and this so-called tunnel interlaminar fenestration, instead of laminectomy or hemilaminectomy, you can do laminotomy or laminoplasty, open door. You may need to do facetectomy, and you may do this unilateral partial or bilateral partial or unilateral complete. And you have the question of stabilization using bone graft or instrumentation. General rule of surgery there, debulk the tumor before you start dissecting, because it's essential. You can see the anatomy better and you can control the bleeding. So here you are showing the vertebrae, and here this is the dura surrounding the spinal cord, and this is where the foramen is. So facetectomy has been done there. Again, dura spinal canal, and this is the schwannoma going through the foramen. So you start with the outside extradural part, and you debulk it, and then you go to the dura component and remove it. So that part is removed, then you open the dura, you get into the dural part, and then you may find some bleeding here, and you pack it with all sorts of things. Some people, as I said, use the semi-hemilaminectomy plus partial facetectomy, like this here. Like this here, it's called the open tunnel approach. And of course, you have the spinal stabilization, and you need this if you have multiple levels, if it is multidirectional, and if you have done facetectomy. Not just partial facetectomy, but total facetectomy which is most of the time is needed, especially in large schwannomas. So this is the type of fixation that you do. And you test stability, inflection, and extension. You may go anterior approach. This is rarely needed. If you go anterior approach, then you have to do corpectomy, and you have to open the dura, and there is a risk there, but sometimes it is needed. This paper, anterior approach for dumbbell type cervical neuronomas, Iwasaki, they reported 4 patients. You may need to combine both. And if you do so, once you start with the posterior approach, then you can put a suture around the nerve root and then go from anterior, looking at where you have put the suture and find the nerve root and start from there. And of course, there is the new approach of minimally invasive using these tubes. People reported removing schwannomas using the tubes in minimally invasive fashion. There are some debates here about the surgery for these schwannomas. Debates about should we or should we not be using methylprednisolone as part of spinal surgery, and they are dealing with the spinal cord. Most of the people are dropping this issue now. Still, people are using it. Should you be cutting the nerve root from which the schwannoma arises? Some people say no, you don't need. Some people say yes. I am with the people who say yes. You have to cut the nerve root at a safe area where there's no tumor. Otherwise, you will have recurrence. And the other third debate is whether or not you should be using neurophysiological monitoring. So methylprednisolone, as you would see people used to do and use in spinal traumas and in intramedullary tumors. And the question, as I said, should we cut the nerve root? Remember that these schwannomas, they arise from sensor roots. And sensor roots are compensated by the nearby roots. So there's no problem in cutting a sensor root. It is not affecting the patient in a big way at all. But definitely by cutting the nerve root in which the tumor rises, the safety margin decreases this is recurrence. So if you cut the motor root, you will get deficits in 23 cases. Why? Because there's some compensation sometimes, but in 2 cases, there's no compensation. So if you cut C5 root, deltoid muscle will be paralyzed. If you cut C8 root motor, then you will have intrinsic muscle paralysis. So these 2 roots are important to preserve, either by removing the tumor completely, or if you need to transect the motor root, then accept the sequences. And if you, as I said, cut the sensory nerve root, then you may get denervation symptoms, but not a majority of cases. What about electrophysiological monitoring? Should we be doing this routinely, or is it depending upon the case? Authors again here differ. Some people would not use neurophysiological monitoring. Some people would use it. I use it in certain cases, not in every case. And this is important when you are sacrificing a nerve root. So it is useful if you have multiple nerve roots coming and adhering to the tumor. So which nerve root to cut? Neuromonitoring will tell you. People say it is not useful because most of the roots are sensory, so don't bother. What kind of intraoperative and neurophysiological monitoring? Sensory evoked responses, motor evoked responses, and EMG. And of course, EMG and nerve conduction studies. So this is cervical, but mainly it is SAP and MEP. And thoracic, SAP, MEP. And lumbar, it is must that you use EMG and nerve conduction in neurophysiological monitoring. So you look at these, SAP, MEP, and you look at 50% reduction in the amplitude or 10% increased latency. This usually denotes nerve injury. What about surgical outcomes? Is it good to deal with these cervical dumbbell neuromas? Let's look at the literature. This beautiful paper, 2006, Nakamura, long-term surgical outcomes of cervical dumbbell neuromas. he could achieve 76 total resection. Anybody who tell you I achieved 100% total resection in all my cases is lying. So sometimes you have to accept defeat and leave some tumor to save the neurological function. And you use the McCormick grading, pre-operative and post-operative, to see whether they have changed, improved, got worse, or patient died, mortality, and so on. What about recurrence? What are the cases that we see recurrence in most of these cases? Increased number, the more number of vertebral bodies, the more injury, and the more residual and the more recurrence. Cranial caudal length, which I alluded to, the length. Large tumor size, you will get recurrence. If you do subtotal resection, you will get recurrence. Sometimes in malignant histopathology, you will get recurrence. And once you get the Ki-67, then you would actually high grade disease malignancy, because usually it is 1 to 2 in the normal tumors, the benign tumors. And if you don't resect the affected roots, you may get recurrence. Complications, of course, like any surgery, sepsis, bleeding, etc. The famous ones are CSF leak, pseudomeningocele, kyphosis, scoliosis. You get sensory denervation symptoms, you get motor, and you get recurrence, and you need to reoperate. So these are examples of the complications, pseudomeningocele and CSF leak. And this is an example of the kyphosis and scoliosis seen after this kind of surgery. My personal experience, I presented to you between 1990 and 2020, 30 years. And out of 389 intradural tumors, I faced 38 tumors. Mostly they were Dumbbell Schwannomas. I had chordomas, I had 2 meningiomas, but most of these cases of Dumbbell tumors were Schwannomas. I present some of these cases. The first case is a Dumbbell Schwannoma C1, C2. You can see there, C1, C2. And you can see that it is within the canal, within the foramen, and going to the paravertebral area. This is a 50-year-old male patient, and this is the tumor. You have to do CT angio there to see the vertebral artery, and you have to check the stability before and after. And this is post-operative, when the tumor was removed completely. This is where the tumor was, the cavity, and this is the patient himself after surgery. Another case of C1, C2, Dumbbell Neurofibroma, a young lady of 38 who presented with this occipital and shoulder pain. Occipital pain, you should be suspicious of higher cervical foramen magnum lesions. So only because she developed weakness and clonus with positive Hoffman and Lermit positive that people did MRI and found this large tumor. So it is really compressing the craniocervical junction and extending through the foramen into the paravertebral area. A huge tumor, large size is important. And this is the post-op, where the tumor was removed without need for any fixation. So these are the post-op and follow-up of this patient. And that's the patient herself. A case of C5, C6, C6, 7, here we have multiple levels, and this is an important case to present. So you can see here, C4, C5, C6, C7, so it is occupying this junctions, C5, C6, C6, C7. Again, this is the cut at C6, 5 here, 6 here, C6, 7 is here, so it's multiple levels and multiple spinal roots affected. You can see the changes within the bone, and you can see the vertebral artery here normal. And look at here, it is pushed and it is narrowed. You don't see any vertebral canal here. Again, you must do the CT angio to see where is the vertebral artery and all of this. You can see it's eating the bone. Here you are, eating the bone, C5-6 and C6-7. C5-6, C6-7. This is the view, and then the canal. And this is the oblique view, which is important. People now tend to forget about these oblique views, how important and how informative they are, where you can see the enlargement of the intervertebral foramen. You can see it here. Let me show you the first part of surgery. Because it is multiple levels and because of the bone erosion, we will show you the first part, where we started with the fixation part of the lesion of the spine. So if you find any instability or expect any instability, you would start by stabilization, and then followed by the surgery from posterior or whatever approach you want to do. So my routine is to stabilize before, if you have any instability, if the spine is degenerative, and if you are going to do facetectomy, if it is multiple levels, then you start with this step first. The second part, of course, this is postoperative after the fixation. And now we'll start the surgery, second part for the removal of the tumor. We record our cases in 3D. Now I'll change it into 2D. So as I said, you start with the foraminal part or the paravertebral part, not the dural part. Here we're using the ultrasonic aspirator. And I meant to show you some of this clips from the surgery to show you the amount of bleeding. That really vascular tumors, they are in direct touch with the vertebral arteries, so they get the blood supply from there. I'm using here the ultrasonic aspirator to debulk the tumor, to stay within the capsule. But in spite of this, still you will find lots of bleeding. Here I'm separating the edge of the tumor from the edge of the dura. This is here the foramen. Facetectomy has been done. It has been done by the tumor. So sometimes you need to do more drilling to see the tumor. But the facetectomy has been done by the tumor, and it was unstable spine. So here you're taking this tumor outside the dural sac, and here once you go into this space, you'll have lots and lots of bleeding. And I did leave this bleeding to show you the amount of bleeding that one can actually face during this kind of surgery. Here we are completing the resection of the tumor, and then you'll face this kind of bleeding from the muscular branch of the vertebral artery. Being prepared for such an incident, you will pass through, and here you're separating the tumor from the extradural space here. This is the nerve root from which it arises. Having debulked the tumor, I open the dura and then remove the intradural part and then continue for the rest of the tumor. But I do debulking first as a very initial step. Here I'm pushing the tumor, which is inside the dura, through the hole that it made for itself to the outside so that I can resect it completely. Again, having done that, I went back and cut the nerve root from which it arises there. You'll find another nerve root here. There it is. So you can see the hole here through which the tumor is passing from intradural to extradural foraminal and paravertebral. Again, pushing, this is the hole, pushing that part outside. This hole must be closed. I close it with muscle graft and suture. It's not enough to put muscle grafts. You have to put the suture around it. And then continue for the rest of the tumor. Close the dura. I usually close it in continuous silk suture, because if you need to go back again for any reason, black silk sutures will guide you. Here's the rest of the tumor. We are going through the foramen outside and pursuing last drop of the tumor. I don't want any recurrence at all. Again, separating it from the extracapsular area here will cause a lot of bleeding. You are working in a very dangerous area. The vertebral artery is at risk. But if you know your anatomy and where to find the vertebral artery, then there is no problem. Some people put flu seal or dural sealant. I don't like. I like to see the bleeding and I like to stop it. It is only in very rare cases that I use the flu seal or dural sealant to stop the bleeding. Here you can see that we are separating it from the vertebral artery, but still lots of branches getting blood supply to the tumor. It has to be controlled. So here we are. This is here another branch for the tumor. Now we'll come across this bleeding again. I really, on purpose, put this views. People think that this is straightforward cases. They are not. They are difficult cases. They are challenging cases. They need mastering of the anatomy there and mastering of the microscopic techniques. So the vertebral artery is just here. Now I'll show you its pulsations. You can see it there. You can see it pulsating. So this extradural part has been removed, the dura has been closed, then you pack this with muscle and gel foam and the dura sealant. So this is the post-op, having done the fixation as first part and then did the removal of the tumor. And this is where we were, and this is the fixation. And this is the patient herself with long follow-up. Another case of C3, C4 Schwannomas. A young Jordanian lady came with this tumor, C3-4. She had lots of degenerative changes, and she had disc disease, degenerative disc disease, and she had modic changes, and she had some instability in addition to this tumor, which is intradural, extraforaminal, and extraparavertebral. So you can see tumor going there, and it is in relation with the vertebral artery. This is the main issue in these dumbbell tumors. Again, see how the foramen is widened. You can see the vertebral artery in its foramen. Here you don't see it. Same thing here, you don't see it here. Again, the amount of damage that these tumors cause staying there for a long time. And the CT angio showing you the vertebral artery being narrowed there against the tumor pressure. So again, the oblique view will show you the widened intervertebral foramen. It is unstable spine beforehand, so she must go for fixation, which was done as a first step before going for the tumor, and now we'll go for the surgery of the tumor itself. Again, it is the same principle, but with different cuts and different videos. Here I'm using the drill to, as I said, the tumor has done the fascicectomy itself, but you complete the fascicectomy to give yourself a better view. This is the dural sac here, this is the tumor. And you start with this using the ultrasonic aspirator. And again, all the time you'll face a bleeding. Having done decompression, opening the dura, get the intradural part, the tumor, and here I'm cutting the nerve root. This is where the tumor arises from this nerve root. So you cut it without any hesitation. It's a sensory root, as you can see. It is in the back side of the spinal cord. So this is the nerve root being cut and the tumor being removed. You do this and then you go back and then close this opening here within the dura. This is the nerve root from which it arises. It's cut off. So I am with the idea of cutting the nerve root from which these tumors arise. Back to the extra spinal canal. Again here, removing the tumor, facing the same thing, the bleeding. Again, coming from the vertebral artery, which is just here, as you can see. So it's been preserved. You pack here and you close here, and that's it. Here again, you put a small muscle plug and you suture it before suturing the dura. So the same principle is presenting to you in various patients. This is the post-op. Remember that we have done fixation beforehand because she had instability of the tumor, and this is the follow-up. This is where the tumor was, sorry. This is the cavity where the tumor was, there and there. Again, no tumor. This is where the tumor was. Spinal cord and the cavity where the tumor was. And this is the patient herself. Another case of C3, C4 schwannoma in this patient. Young patient from Kurdistan, Iraq, 16-year-old. Again, same principles. Widening the intervertebral foramen and going outside. You can see the vertebral artery here, you don't see it here. Again, vertebral artery being narrowed there, compare it with this side. We know that the left vertebral is dominant, but in this case, this non-dominant vertebral artery is the left side, and the right side is narrowed. Amount of bony destruction it causes. And the fixation that we've done as a first step of dealing with these cases. So we'll show you the video. Following the same routine, dealing with the paravertebral or the foraminal part first, leaving this last, using the ultrasonic aspirator, taking the tumor there. And here we can show the hole through which the tumor went through. So this is the hole within the dura at the site of the origin of these tumors. Region. So here you are, we are cutting the nerve roots. So again, the same routine, muscle plug or fat plug with Surgicel and Duracell and so on. Okay, we'll finish with that. This young man done very well, has been stabilized and his tumor removed, and has been followed for about 7 years now. He's doing well, he's growing well, he's going to the university. Another case of C1, C2, Schwannoma, in this 58-year-old patient with quadriparesis and pyramidal signs. Again, you can see and appreciate the tumor going through the foramen. The CT angiogram to show the vertebral artery and the surgery itself. And this is the last one. I'll be finished in about 1 minute. Just to show you this interesting case and the relationship of the vertebral artery, which you can see here, and the venous plexus, the so-called the vertebral cavernous sinus. This is the nerve root. It's been cut at the safety margin. The vertebral artery has been mobilized. And once you start removing the tumor, you will have lots of bleeding coming from these plexus of veins. Opening the dura, getting the interdural part with the color of the dura around it. These are rootlets here, dorsal rootlets. But we have mobilized the artery here, the vertebral artery is here. We have mobilized it completely. And now we'll come to the nerve roots where the schwannoma did arise, and without any hesitation, you cut that nerve root. C2 nerve root is not much of any deficit for the patient. It's compensated by the others. But here they don't rescue any recurrence. Having done that, you have to patch the dura. You can see here the spinal accessory going up. You can see the vertebral artery here. V4 is here. And you can see it's the extradural part. So this is the vertebral part outside the dura, and this is inside the dura. And the tumor was there. You do dural patch and Duracell and so on. So this is post-operative MRI without any complications and a long follow-up. And the patient, this is her first day, and she was so happy that when she came, she was quadriparetic. She could not stand. Now she can, and that is the merits of this kind of surgery. With this, I finish. In conclusion, dumbbell schwannomas, or dumbbell tumors in general, are challenging lesions because they lie in 2 or more anatomical areas, and the surgical objective is to do neural decompression, radical excision if you can, but with the preservation of spinal stability and minimizing any tissue damage. Thank you very much for listening. I'm happy to take your questions and comments.
Okay, great. Thank you very much, Dr. Sabaya. And the floor is open for comments. I
have a comment. Yeah, I see Dr. Abu Farsakh, our pathologist. Do you want to comment on these schwannomas, Hassan?
Yes. Yes, actually, the second case that Dr. Ibrahim Speh presented, she's a friend of mine, and she called me about 6 years ago from one of the Gulf states, and she visited several neurosurgeons there, and they told her this is very, very difficult surgery, and nobody can operate on this case. You have to have danger of paralysis or phrenic nerve damage. And she was afraid. And then she called me from one of these Gulf states. And I told her, don't worry, Dr. Ibrahim Speh is really very capable of doing these surgeries. And she has dumbbell tumor. And she came in and she did extremely well. I'm following her up. And actually, I called her several weeks ago, and she is doing very, very, very well. So what is very difficult in some areas by different surgeons, maybe is not difficult in the hands of Dr. Ibrahim Speh. And this is a a certificate that I can certify from my own experience with Dr. Ibrahim Sbeh on this case.
Thank you, Hassan.
Thank you.
Can you make any comments about Antony A, Antony B value, and so on?
Actually, these tumors, it's the main differential in morphology is Schwannoma, Neurofibroma, and meningioma, and we do several stains to separate them from each other. The Schwannoma, usually they have Antony A, Antony B. Neurofibroma, usually they don't have it. Schwannoma usually are well circumscribed, and the recurrence rate is really low compared to neurofibroma. Factor 13x, one of the factors that differentiate between Schwannoma and neurofibroma. The other one is meningioma. Meningioma, I usually do multiple immune staining to separate both of these entities because the management is different. If you call it meningioma, usually you have to go also after the bone. If you call it Schwannoma, probably they don't go after the bone, the neurosurgeons. I usually do multiple immune staining, not only one to confirm my diagnosis, I do multiple, so the diagnosis, the final diagnosis will be really accurate, whether it is neurofibroma, Schwannoma, or meningioma.
So what about these Verocay bodies?
These Verocay bodies, they are actually part of the histological features that's seen in Schwannoma, and when we don't see them very often. We see them in about 20 to 30% of Schwannomas, and we see them. It's really very good mark that this is a Schwannoma, not a neurofibroma, and not a meningiomas.
Yeah. Thank you, Hassan.
Thank you.
Any other question or comment?
Yes.
Go ahead,
Please.
Saeed. Go ahead.
Yes. Thank you very much, Dr. Jean Bennett, for all this effort. And thank you very much, Professor Ibrahim Sbeh, for this very nice lecture.
Thank you.
And for all these, congratulations for all these webinars you presented.
Thank you very much.
I don't know why sensory nerve motor are affected more than motor nerve. I don't know why.
Nobody knows why. Nobody knows why.
We have this phenomenon also in intracranial compartment, like for trigeminal
Yes, vestibular Schwannomas,
acoustic neuroma, etc.
Yeah.
Do you have experience with the L4, L5 neurinomas? Because there is
Yes, I have a number of cases, I have thoracic cases, but the topic for tonight is cervical schwannomas, so I presented the cervical ones. But yes, I have lumbar and I have thoracic ones.
Did you have a motor deficit during post-operative period or not? For
Yeah,
this
you have to tell the patient, that sensory or motor deficit is affected. You are dealing with from nerve roots or L5 nerve roots, etc., etc. So you have to warn the patient either you leave a part of the tumor and risk recurrence, or you would accept this deficit being motor or sensory in case you remove or cut the nerve root. I always tell the patient to accept that risk.
You use obviously intraoperative neuromonitor for
Absolutely, yes.
Thank you.
Thank you.
Okay, more comments, questions? The Harshad, I guess, had to leave. Okay, Dr. Sabea, I guess we'll go on to the Kahoot. 10 questions that you made up from your presentation.
Absolutely.
Okay, so let me screen share this, and I'm putting the links. You basically vote with your smartphone, and you go to the kahoot.it, www.kahoot.it. Let me screen share that, matter of fact. Sorry, hold on. Okay, let me screen share this. It takes a little bit to set up. Okay, here's the information that you need. go to, on your smartphone, go to www.kahoot.it and you put the game pin in on your smartphone. It'll ask you for a pin. Is this one particular to this webcast is 971-5928. It'll take a while to get a couple people in here.
Sure.
Two, eight. Okay. Just once again, on your smartphone, go to www.kahoot.it. Okay, and that next screen, it'll ask you for a pin. You punch in 971-5928. Just says the other three associates here on the screen. Okay, I think we'll start, Dr.
Sure,
Sabea, and the
Yeah.
other people will join.
Sure.
Okay, now the question is going to come up, and you can answer by the color of the answer. So you, okay, here we go. Okay, Schwannomas constitute what percentage of dumbbell spinal tumors? Okay, just pick the color on your smartphone, red, blue, or yellow. Okay. Okay, 3 of them are correct. And that's a good start.
Well, 50% of the dumbbell spinal tumors are Schwannomas.
Oh,
It's
okay,
not-
I'm sorry. I'm
Yeah.
sorry. Everyone missed that one.
Right. So it's
Oh,
not
okay.
20%, it's not 90%, it's just half of these cases that are really due to Schwannomas. They are dumbbell and they are due to Schwannomas. The other 50% are meningiomas and other tumors, especially from the bone, chondroma, chondrosarcoma, osteoma, osteosarcoma, and so on and so forth. So 50% of the
Okay.
dumbbell spinal tumors are Schwannomas.
Okay, very good. Okay, next question, the same thing. And they actually rank people. Well, I guess no one got it right, so no one's in the
No.
lead.
Yeah.
Okay, dumbbell schwannomas constitute what percentage of all spinal schwannomas?
So we have spinal Schwannomas, either intradural or foraminal or outside the dural sac. How many of these Schwannomas of the spine are really dumbbell?
Okay, A. And that's not the correct answer, right?
The correct
Doctor?
answer is 15%. So
15.
spinal dumbbell spinal Schwannomas constitute 15% of all spinal Schwannomas.
Relatively low. Okay, very good. Go on to the next question.
Sure.
Okay, we got a lead here. Someone's got the right one. Okay. Okay, next question. Regarding neurofibroma, which of the following statements is false? Okay, they are easily separated from the nerve they arise from.
This is the false one. because they are not easily separable. You cannot separate them from the nerve root. This is the difference between a neurofibroma and the schwannoma. Schwannoma, you can separate it from the rest of the nerve roots or fascicles, while neurofibroma, it is stuck together because it arises from the neurofibroblasts, from fibrous tissue within this fascicles. So you cannot separate it from other fascicles of the nerve. So the false statement about neurofibroma that they are easily separable, they are not.
Very good. Okay, next question. Okay, there's a change in the ranking. Charming Bobcats heading it. Okay, in its neuroanatomy, V2 segment of vertebral arteries is in which of the following? Okay, the correct answer is
The correct answer is that it is from C2 till C6. This is the correct answer.
C2 to C6.
Yeah.
Okay, very good. Okay, the next one. Schwannomas arise mainly from people answer that pretty quickly.
Yeah.
I think they got that one right. Okay,
The posterior roots is the correct answer.
those posterior rootlets is the correct one, huh?
Yes, it is the sensory root, yes.
Okay, very good. The cervical transverse foramen, the vertebral artery is in what relation to the nerve root?
So what is the relationship between the vertebral artery and the nerve root in the cervical vertebrae? The correct
Okay,
answer, it is
okay,
anterior to the root, yes.
Okay, the people are getting smarter. All
Yeah.
right. In cervical dumbbell Schwannoma surgery, the least appropriate neurophysiological monitoring is
Is it sensory local responses? Is it motor local responses? Or is it the EMG and others?
okay. EMG is the correct answer.
Is the least appropriate. You use EMG more in the lumbar area.
Right, the least appropriate, not the most.
Yes.
Okay. Sacrificing anterior root of C8 will result in which of the following?
Can we sacrifice C8 roots or not? No appreciable deficits, or just weakness of the extension of the wrist, or weakness of the intrinsic muscles of the hand?
Hey,
Correct answer is-
everyone got that right. Wow.
Yeah,
Okay, very good. They're listening, Dr. Sabaya.
and that's the idea. Now we're talking about Antony A and Antony B zones. Antony A zone in particular, one of these statements is false.
Okay, the correct answer. Is that the correct
Yes.
answer?
Yeah, the correct answer. Antony,
Okay.
we are talking about a false statement about Antony A. And because Antony A is a very cellular area, it is highly cellular. So if we say Antony A is a scanty cellular, is a false statement.
Okay, very good. The last question, which of the following statements is correct about multiple schwannomas?
Is it NF1, is it NF2, or is it malignant?
Everyone answered? Okay, is that the
It
correct
is
answer? That's the correct
yes.
answer. Okay,
NF2
the
is the correct
majority got it. That's ending on a good note. Now here's the final scores. Snowy Gecko, number 3. showing Bobcat number 2.
Right.
And the high score goes to, no, I don't know what it went to. I'm sorry about that.
Don't you worry.
Oh,
worry.
man, I just put the next screen.
No
So
problem. No problem.
unfortunately, okay, very good. That was good, Dr. Sabea, to go
Yeah,
into
very-
areas that you want to kind of highlight.
Sure.
So, okay, do you have a topic for
Yes.
a couple of weeks?
Next time, in 2 weeks' time, we'll be presenting the falco-tentorial meningiomas, a very unique subtype of meningiomas. Meningioma can occur anywhere, convexity or skull base, paraspinal, parasagittal, falcine. But a very unique place is the falco-tentorial junction of the forks with the tent. This is a very difficult situation, and we'll discuss the intricacies of this kind of tumor, falco-tentorial meningiomas.
Very good. Okay, we look forward to that. And thank you for all the panel for coming.
Thank you very much.
Okay,
See you.